today will be as it is when we're usually in the Park Street Auditorium. 2 talks. We'll have time after each presentation to take your questions on the chat line and when we get started. So our first speaker, I think, addresses the pivotal area of the intersection between immunology and virology, certainly a very topical area of disciplines given our current pandemic. But Dr. Brinda Emu, as many of you know, has looked at this in the context of HIV-associated cancer, which is an evolving topic. Dr. Emu is an associate professor of medicine, infectious diseases at the School of Medicine. Her laboratory really looks at the impact of immune dysfunction on cancer biology, as well studying HIV, where our understanding of the relationship between HIV and cancer, when that virus became apparent, I think our understanding is different. And clearly there are cancers now on the list that weren't previously understood when HIV was first being studied. So Brinda, really appreciate your presenting today on our virtual Grand Rounds and look forward to your discussion.
Thank you. Thank you, Charlie. Thank you for inviting me to speak here. I'm really excited. Just want to check you can hear me okay?
Yes.
Okay, perfect. So I am going to talk about HIV and cancer, and I do think it's very timely. I just have this one slide here that came out yesterday in a press release. So I went into medical school when the HIV pandemic was in its early days, and Yale and the commitment to the community in New Haven, which was disproportionately hit and continues to have a very high rate of HIV. There was a real impetus from Yale and providers here, and the community healthcare van was started in 1993, the first van in the country to bring medical care to the community. And I just wanted to give a shout out to Rick Altiz, because it's being repurposed in the last couple of weeks to provide information to the community about COVID-19, distributing PPE, and providing care to mothers and newborns. So it does remind a lot of us of why we got into medicine as we are engaging with this new pandemic. So these are my conflicts. So I want to start.
Do you want to share your screen?
Oh, sorry, you didn't see my picture of the van. Hold on a second. Sorry. Okay, are you able to see it now?
Yes, thank you.
Okay. All right. There's the van. And okay. So I'm going to start with a case. This was a case that I shared with Dr. Goldberg here in the Cancer Center. So this is illustrative of what I'm going to be talking about today, which is HIV and immunology, and then lung cancer in particular, which is a non-AIDS defining cancer. So this patient is a 50-year-old African-American female. She was diagnosed with HIV 30 years prior. She presented in September of 2014 with pleuritic chest pain and a 50-pound weight loss, which had been occurring over the prior 9 months. Her HIV care was very stable, so we don't see our patients, sometimes just once a year. A chest X-ray done at that time showed a new left upper lobe lesion, and a CT scan showed a 3 by 3.5 centimeter left upper lobe mass with extension into the chest wall with involvement of hilar and mediastinal nodes. She completed staging with a PET scan, which showed disease only in the left upper lobe, leaving her with stage 3A disease. She was deemed not a surgical candidate. Really, her only past medical history was HIV and vitamin deficiencies. So the HIV was diagnosed in 1989. Her CD4 count recovery is excellent. She had over 1,000 cells, which is normal. Her CD4-CD8 ratio, which is we're now measuring pretty routinely, was 0.9, and I'll talk about that a little bit later. Her virus was suppressed on antiretroviral therapy, and she had no history of opportunistic infections or any AIDS-defining illnesses. She did have a 35-pack year smoking history and had just recently quit, no alcohol or drug use, and lived with her 3 daughters in New Haven. She was on 4 drugs, 3 NRTIs, and a protease inhibitor for her HIV care. And on physical exam, she was fatigued and cachectic, had evidence of clubbing, but nothing else really remarkable on exam. So her course, she initiated chemotherapy in February and then started radiation a month later. And after 4 rounds of therapy, she appeared to be disease-free. In June of 2015, she had a CT scan of her chest, which showed stable disease. In August, she was seen in HIV clinic and remained symptom-free, but a month later presented with cauda equina syndrome with evidence of multiple lesions in her cauda equina, L3 vertebral body, and she underwent XRT and stabilized. At that point, immunotherapy was being contemplated for the patient, and that was the one and only time that I met her because she wanted to speak with an HIV doc about it. And we talked about the fact that the drug hadn't really been tested in HIV, and the pros and the cons, and she was very worried about that and did not want to start immunotherapy. But I think as her disease progressed, that decision was being contemplated, but unfortunately she died of a pulmonary embolus before she could initiate treatment. But this case illustrates a lot about cancer in the setting of HIV, and I'll come back to this case throughout the presentation. So this figure shows the HIV epidemic, and it's a classic figure, and I got into medical school right here in 1994 as cases of AIDS and HIV were climbing. But in 1996, the first combination antiretroviral therapy regimen was used, and you can see this dramatic decrease in the number of AIDS diagnoses and the number of AIDS deaths. And our patients with HIV, we have great antivirals right now, are living long and healthy lives with their chronic infection, but there are thousands of new infections every year, meaning that the prevalence of HIV continues to increase, and it is still a pandemic by WHO criteria with almost 40 million people infected, and that number continues to grow. But the mortality and what people are dying from among people living with HIV has changed quite a bit. So in red, each bar here represents 1 year since 1996. And you can see in 1996, 80% of deaths were due to AIDS-related causes, AIDS-defining illnesses. And that dropped dramatically the next year with antiretroviral therapy and continues to decrease over time. And here in purple is mortality due to cancer. And you can see that there's a clear increase over time in the number of cancer-related deaths among people with HIV. In fact, cancer causes about 15% of all deaths in the HIV population. It is the leading cause of death among people living with HIV in the United States, and it's growing all around the world. So with 35 million people infected, this is actually quite a major global health issue. And when we talk about cancers, as everyone knows, there's AIDS-defining cancers and non-AIDS-defining cancers. And the AIDS-defining cancers are Kaposi sarcoma, lymphoma, non-Hodgkin's lymphoma, and cervical cancer. And those are depicted here in blue. And in the solid blue are those over the age of 45, and in hashed blue are under the age of 45. And you can see from 2006, and this is goes through 2015, and everything else is projected, that the rates of AIDS-defining cancers have declined and are expected to continue to decline through 2030. And in red are the non-AIDS defining cancers. And these are actual numbers, not proportions. And you can see that the numbers of non-AIDS defining cancers have been increasing since 2006 and are expected to continue to increase as this population gets older. Now, the makeup of what types of cancers we're seeing among people with HIV has changed. So in 2010, the majority, the leading cancer type was non-Hodgkin's lymphoma, followed by Kaposi sarcoma, and then lung cancer. In 2020, where we are right now, prostate cancer and lung cancer lead the list. And in and with lymphoma being third, and by 2030, none of the AIDS-defining cancers are in the top 3. So prostate cancer and lung cancer and hepatocellular cancer are predicted to be the most common cancer subtypes. And in terms of mortality, lung cancer is the leading cause of cancer death among patients with HIV. This has been looked at in multiple large cohorts, followed by lymphoma and hepatocellular cancer. So the incidence of lung cancer is 2 to 4 times that of the general population. And though our patient population does have a high rate of tobacco use, HIV is an independent risk factor, and that's been looked at multiple large cohort studies. And lung cancer alone represents about 4% of deaths among those with HIV. And the mean age of diagnosis is quite young, so almost 2 decades younger than the general population. Now, some of that skewing is because the HIV population as a whole is younger, and so I expect that mean or median age to increase. But it is striking, as was seen with our patient, that we see a fair number of patients who are in their 40s and 50s being diagnosed with advanced lung cancer. Almost universally presents with advanced stage, and patients with lung cancer, like almost every cancer in the setting of HIV, have a worse prognosis compared to the general population. So I'm going to jump to data actually from Yale. So this data was collected by Kristen Heisel, who was a medical resident and is now an infectious disease fellow, and Sarah Goldberg helped us do this analysis, and it's submitted for publication. And I think it illustrates one of the, this has been looked at in large cohort studies, but we were very interested to look at a single institution experience where we have the same HIV doctors and we have the same oncology providers, because a lot of the large databases, because you have data coming in from multiple places, and there are disparities in terms of treatment across different institutions, it's hard to tease out what the differences in outcome are due to the type of treatment that patients received. So this is our Yale experience from 1998 to 2015. So we looked in EPIC for all of the cases of HIV and lung cancer, of which there were 35, and compared that to the general lung cancer population, which is over 5,000 individuals. And you can see here again, the mean age of diagnosis is about 15 years younger among patients with HIV compared to non-HIV. We have a very diverse population in terms of our patients living with HIV in New Haven, which is reflected here in terms of the differences in race and ethnicity. But we did not see any differences in terms of presentation, stage, or histology type. But what we did see is that survival, and I don't have the slide in here, so the treatment approaches for patients with HIV and non-HIV by any stage that you looked at were comparable. So we did not find that there was any differences in the approach to treatment at Yale between the two groups. But what we did find is, despite that, there was a difference in survival. So in HIV positive individuals, the median survival was 12 months compared to 23 months in the HIV negative group. And the factors in a multivariate analysis associated with poor outcome were age, male sex, stage, and HIV. And among the HIV infected individuals, having detectable virus was associated with poor outcome, but your CD4 count was not. And that's something I will come back to. So the two questions regarding HIV-associated cancer that we're really interested in is, what are the mechanisms that play a role in the differential cancer risk among HIV-infected individuals? And then what are the differences in the actual tumors of patients with HIV that may inform prognosis or treatment decisions? And are they different from those without HIV? And our hypothesis, I come from a background of viral immunology, is that the defective immunosurveillance that we see in the setting of HIV ultimately leads to limited tumor-specific responses, which both increases cancer risk and also favors local progression of established cancers, ultimately leading to worse prognosis. So I'm going to switch to our immunology work, and really as someone that's done viral immunology for the last 15 years, looking at cancer in the tumor microenvironment, I sort of appreciating the synergies in terms of the response to tumors and the response to viruses. So I really think of cancer as a chronic infectious disease in the tumor microenvironment. So just this is 30 years of HIV immunology on one slide, but I just want to highlight the hallmarks of untreated HIV infection, which are CD4 T cell depletion, chronic immune activation, and immune dysfunction. And that happens after HIV infection. You see, almost immediate peripheral CD4 T cell depletion. A lot of that is redistribution, but certainly a lot of it is direct T cell death as well. And that T cell depletion leads to microbial translocation as well as co-infections replicating, leading to a state of chronic immune activation. And that immune activation, even after antiretroviral therapy, results in a state of T cells, particularly, that seem to have dysfunctional responses to antigens. They have an exhausted anergic cell type, however you want to define that. And then in addition, because of the chronic immune activation, you have a lot of circulating pro-inflammatory cytokines. And unique to HIV, you also have destruction of your thymic architecture and little ability to sort of recapitulate or reconstitute those lost T cells. But the big question is whether, in the setting of antiretroviral therapy, particularly, whether any of these features actually result in cancer development. So this is data, so getting back to the CD4-CD8 ratio. So there's certain features of the immune response despite antiretroviral therapy that do not become normal. And one of them is the CD4-CD8 ratio. And you can see a normal ratio on the left is 2, and that really persists for for most of your life. It's really rock stable at 2. On patients in patients with HIV, not only do you get CD4 T cell depletion, but you get a massive expansion of CD8 T cells, which dramatically flips that ratio. But once you get on antiretroviral therapy, that ratio still, for the large part, remains very low compared to uninfected individuals. And we get pretty excited if we can get that ratio up to 1, but the average rate is about 0.5 to 0.75. In addition, we see a skewing of cells. This is CD8 T cells from naive cells towards terminally differentiated cells on going to the right. And you can see despite long-term antiretroviral therapy and viral suppression, there's still a significant skewing of cells towards a terminally differentiated state. And this is work that I did with Shelley Farhadian, also an infectious disease here, looking at over time, we see a maintenance of these terminally differentiated and activated cells. It is not synergistic with age, so everyone as they age accumulates more terminally differentiated cells, so that slope is not increased, but patients with HIV have higher proportions of these senescent cells and activated cells that persist. So in terms of, is this a predictor of mortality? There's some evidence now to suggest that it is. So a couple of studies I'm showing here, one on the right, demonstrated that patients with HIV that went on to have non-AIDS malignancy had much lower CD4-CD8 ratios compared to those on the left without any non-AIDS conditions of any kind. And on the right is our work done by Omkar Chowdhury in my lab that showed that in black here, these are patients that are HIV infected. These are cells that we had prior to their cancer diagnosis, so at least a year prior to the cancer diagnosis. And you can see patients that went on to get cancer had higher rates of these exhausted T cells compared to here in white, those patients who had HIV that did not have a cancer diagnosis, suggesting that this highly exhausted evidence of immune dysfunction actually precedes the development of cancer. So Ramsey Youssef is a medical student here, has been working with me for 3 years. We wanted to take some of this information that we had in the peripheral blood and see what's happening at the level of the tissue. So Ramsey identified those 35 patients that we had at Yale. 18 of them had tissue that was available for analysis, and he matched that to HIV negative non-small cell cancer tissue, and we matched it by age, smoking status, year of diagnosis, histology, and stage. So we had a good comparative group. And so all of the work that I'm going to show you now, from now on, is in collaboration with Kurt Schaper in the Department of Pathology, who has really been my partner in all of these studies, and has really taught me about the tumor microenvironment and immune responses there. So this data has all been done in collaboration with Kurt. So we started with looking at immunofluorescence and looking at both tumor and the area surrounding the tumor, the stromal compartment, and looking for presence of PD-L1. PD-L1, as we know, is expressed on tumor cells and is felt to impair T-cell responses against the tumor through inhibiting through signal through the PD-1 receptor, which is an inhibitory T-cell receptor. And you can see that in patients with HIV, there's a higher proportion of individuals who are PD-L1 positive compared to the HIV negative group. However, whether you're PD-L1 positive or not in the setting of HIV does not seem to impact survival. In addition to having a higher percentage of patients with PD-L1, the expression of PD-L1 also appears to be higher in patients with HIV in gray compared to uninfected in white, that this was not significant. The one situation where we did see significant increases in PD-L1 were in patients who had HIV viremia and were not on antiretroviral therapy. So one question we had are T cells actually even getting into the tumor microenvironment? Does something about HIV prevent migration? And we did not see that. So we see almost similar, and in CD8 cells, even more T cells entering the tumor environment in patients with HIV than non-HIV. However, as opposed to the general population, the number of cells that actually were in the tumor was not associated with outcome, sort of suggesting that perhaps the T cells were there, but not functioning the way we wanted them to. So to analyze the T cells in greater detail, we embarked on using imaging mass cytometry, IMC. So this allows us to use CyTOF technology with markers stained with multiple antibodies. I think this is a 40 marker, actually 37 marker panel. And the ability to do that in tissue as opposed to blood allows you to also maintain the architecture of the tissue while you're looking for expression within the individual cells. And Kurt's lab with Franz and Shruti Desai had done some really laborious work to really demonstrate that the markers that they used have been validated with using immunohistochemistry versus IMC. You can see here, looking at the same tissue stained in the two different methods, that you see nice and comparable discrimination of cells by, in this situation, CD3 and cytokeratin, but that type of validation was done for most of the markers in this panel. So what we did after staining our HIV positive and negative slides, we get this, this is the histology under light microscopy. We get an image from the CyTOF machine that we can look at through the MCD viewer and highlight the antibodies or the markers that we're looking at. In this situation, we've picked DNA to mark cells, CK to mark tumor, and then CD4 and CD8. and then using an automated system through Cell Profiler where you can provide input in terms of using DNA to designate a cell as a cell, and then providing size specifications, the program will actually segment those cells for you. So this is an example of automated cell segmentation, and though it's not perfect, you can see that you can see that those tumor cells and CD4 and CD8 cells segment without any manual gating, which saves a lot of time and also allows for a larger analysis. So when we looked at these cells, Ramsey then went ahead and used another program, Phenograph, to try to look at particularly the CD8 cells within HIV positive versus HIV negative tumors. And you can see on the right here that in an unsupervised way, 5 different clusters of CD8 T cells were identified based on their marker expression. And if you look on the left, HIV positive cells from HIV positive tumors are in blue and in HIV negative in red. And you can see that there are some subsets that really are only defined by patients with HIV and others that in patients without HIV. And so when you look at the distribution of these two subsets between HIV positive patients and HIV negative patients, you can see that there's very different proportionality in terms of the CD8 subsets. And then if you look on the left, these are the different subsets, 1 through 5. For example, in the HIV negative subset, you can see that there's one of the HIV negative subsets here, subset 3, that there's high levels of LAG3, TIM3, and PD1. Now, if you recall, we thought that there would be a high level of these markers in the HIV positive groups, and you can see that the 2 subsets that are predominant in HIV positive groups, one of them has high levels of these inhibitory markers, but the most prominent HIV positive subset has moderate expression of these markers, not as high as some of the others. So it was intriguing that the CD8 T cells within HIV have moderate, but not super high levels of T cell inhibitors. And one of the most exciting, and I think, at least for me, not predicted outcome was the actual distribution of tumor cells within patients with HIV and without HIV. So similar to the CD8 unsupervised clustering, when we look at the CK positive cells, you can see that there are 7 different subsets of tumor cells. And again, when you look at those cells distributed from which patient they came from, there are certain subsets that are seen only in the HIV positive individuals. So this would be cluster 2 and cluster 4. And once again, if we look at the distribution, which was very significant between the HIV positive and HIV negatives, these clusters that are seen in the HIV positive group, and here are some clusters that are predominant in the HIV negative tumors. And what's really striking, and this data is quite new, so we have still a lot of analysis to do, is that the MHC class 1 proteins, HLA-ABC and HLA-DR, are in all of the HIV positive tumor subsets are really expressed at a very low level. And here's PD1 here, so there's really variable expression of PDL1 here, but universally sort of an absence of the MHC class 1 proteins, which suggests that the tumor cells within HIV positive patients have decrease in antigen presentation machinery, which is a really interesting and finding, and suggests that perhaps with chronic HIV infection that the tumor has adapted mechanisms to evade the immune response, including decreasing antigen presentation. So I'll very quickly say where we're going. So this analysis was done in collaboration with Yuval Kluger, also in the Department of Pathology, which is taking that same IMC data, but using machine learning to take each patient or a subset of the patients and looking at the phenotype of each pixel within the the IMC profile that we looked at. So instead of segmenting by cells, we look for areas where there's high levels of CK expression or high levels of CD8 expression, and then look for the expression of all 40 markers in those areas. And by doing that across a bunch of patients, and then after that, the profile of those cells is obtained and analyzed, you then sort of declassify those patients in terms of HIV positive or HIV negative. And then using machine learning, the program tries to identify what are the features of HIV positive and HIV negative tumor cells that are different. And then you can apply this to a new cohort of HIV positive and negative individuals to see whether the algorithm in terms of differentiation bears out. And here is HIV positive and negative cells in the matrix using this algorithm. And though the mathematics is quite complicated and Yuval would have to talk you through it, what the result was that with an 85% accuracy, this algorithm could distinguish in a new subset of patients which ones were HIV positive and HIV negative. So this is really exciting because now we can go back to the data and look into what features and what particular markers or pattern of markers allows for that distinction to say that one particular tumor type looks more like it came from an HIV positive individual versus an HIV negative individual. And I wanted to also show you this data. So I think, you know, where we started with, and we're still very interested in, is in the immune infiltrative HIV tumors, is what's happening at the tumor level as well, because obviously there's interplay between those cell populations. And in collaboration with Hongyu Zhao and students in his lab, we found that when you look at the HIV negative individuals here in red, and we did whole exome sequencing of our HIV positive cohort. This is our Yale cohort all the way on the right, and an NIH cohort in the middle, that patients with HIV-associated lung cancer had much higher levels of non-synonymous mutations as well as neoantigens, suggesting that these tumors, in the absence of immunosurveillance, are going somewhat unchecked with a much greater number of genomic alterations compared with HIV-negative tumors. So that was my last data slide. So I'm just going to conclude by saying that what we have found is that we know that there's evidence of peripheral immune dysfunction, and we have found that some of those seem to be prognostic of cancer incidence. This looks like I didn't finish that sentence, but the tumor microenvironment of HIV does appear to be very distinct from that of HIV negative lung cancers. There's increased PD-L1 expression. However, the T-cell infiltrate is not associated with improved outcome, and it's quite heterogeneous, and I think we need a lot more cells to really, or a lot more patients to really deconvolute that. But we do see alterations in both adaptive and innate immune cells. I didn't show you the innate data today, and that the tumor cells are interesting, and they have evidence of impaired antigen presentation, thus able to avoid immune evasion, and also have increased mutational burden. So we're really excited about this data. There's a lot more analysis to do. As you can imagine, 18 patients with HIV, some are on therapy, some are not on therapy, so the heterogeneity of what we find is large, but between Kurt and myself and some other collaborators, we expect to have more than 200 samples of HIV-associated lung cancer that we're going to be analyzing, so we can really deconvolute this data, look at what is associated with certain clinical phenotypes, and to determine how it actually might impact treatment decisions. So there's a lot of great collaborations that are ongoing, including the potential development of a humanized mouse model of HIV and lung cancer with Dr. Richard Flavell and Mike Shirazzi, as well as thinking about biomarker development. So I'm going to stop there because I think we're close to end of time, and my thank you slide seems to be misplaced here. So, but there are a lot of people that were involved in this work. I hope I mentioned most of them along the way. I wanted to also give a shout out to Saeem Salahuddin in my lab, who's doing comparable work on the side in head and neck cancer. But this has really been an interdisciplinary effort with folks in pathology, immunobiology, biostats, and medicines contributing to the data.
Well, Brinda, thank you. That is an extraordinary body of work that is not only informing how we can manage HIV patients and the associated biology, but I think is going to be important in terms of the immunology of these common cancers. So it's